Hi everyone, my name is Dr. Harish Malapura Maheshwarappa. I am working as consultant in critical care medicine. So today I am going to discuss an important topic, that is disease specific nutrition. So we are aware like lots of confusion what to avoid in a patient with renal failure or respiratory failure, how to feed the patient with pancreatitis, or if the patient is having hepatic encephalopathy, should we restrict the protein in particular condition, or is it okay to go ahead? So maybe in another couple of minutes I'll just give a brief summary. So what is the current role of so-called disease specific nutrition? So when it comes to some global recommendation, so there is no recommendation strictly from ESPEN or ASPEN whether to you have to go for particular disease specific nutrition, but you have to remember some sort of key messages when it comes to specific disease. Here we go. So first, so general critically ill patient who are septic, we know that most of the patients who we get in ICU, near about 30 to 40% chunk are going to have sepsis, septic shock at one moment during their admission. So how to feed them? So you have to remember the feeding. So initially we have to worried about their calorie supplementation. It's may not be always true, because like they require protein supplementation initially in a good way, because they are going to have high catabolism during the initial phase. So basically when to feed them, so as early as possible. So don't wait for 48 hours, 72 hours and all. So if the gut is functioning, so use it as early as possible. We don't want 100% achievement of the calorie requirement in the initial around 7 to 10 days. If we are able to achieve around 50 to 65% of their calorie requirement, it's more than enough. So we have to consider giving at least 20 to 25 kilocalories per kg per day, protein somewhere around 1.5 to 2 gram per kg per day. So in septic patient there is no specific recommendation for any sort of like disease specific nutrition. So when it comes to respiratory failure, so there was a myth. So in a respiratory failure patient, particularly in type 2 respiratory failure, so there is a high amount of carbon dioxide will be there. So you avoid carbohydrates in that patient. That was the myth, so followed for many decades. Current evidence doesn't suggest any sort of carbohydrate restriction. So we can give adequate carbohydrate, protein and fat. So along with, we have to consider, keep a watch on phosphorus, because phosphorus will help in weaning from the ventilation. And maybe once we adequately resuscitated, you have to consider a bit on restrictive strategy for the fluid therapy when it comes to respiratory failure. So again, in renal failure, one thought process which practiced for the decades was like we have to restrict proteins in them, because they are going to be converted to creatinine and which worsen the renal failure. This is not true in the current practice, because so don't restrict the proteins just to minimize the frequency of need of dialysis or to postpone the dialysis, because I told, so proteins in critically ill patients are very essential. So in ICU, in critically ill patients with renal failure, those who are on CRRT or intermittent hemodialysis, lots of proteins are and carbohydrates are going to be lost in the dialysis. You have to supplement at least 2.5 gram per kg per day. So those who are on dialysis but you are not done dialysis on a particular day, you can give somewhere around 1.2 gram per kg per day. So remember, don't just blindly restrict the proteins in renal failure patients. When it comes to hepatic failure, so there are lots of things happened. Okay, so if you restrict the protein, so then less production of ammonia, less hepatic encephalopathy. This was the myth. So current recommendation, no need to restrict the proteins in hepatic encephalopathy if you are able to manage the hepatic encephalopathy medically. In a patient who is refractory to medical therapy, so then only you can consider restricting proteins. And there is no clear evidence for branch chain amino acids like L-ornithine, L-aspartate. So you can consider all these branched chain amino acids in a refractory hepatic encephalopathy. By and large, don't restrict in a patient whom you can treat properly is hepatic encephalopathy. So again, acute pancreatitis. There was a myth, okay, don't feed enterally in a patient who is having acute pancreatitis because it may worsen the autodigestion of the pancreas. But current evidence suggests you have to consider feeding as early as possible, preferably enteral route. So which route to choose, nasojejunal or nasogastric? So evidence suggests there is no difference between nasojejunal or nasogastric. It is very important to consider early feeding than the route. So again, suppose if they are not tolerant, so in a patient with severe acute pancreatitis, they might have severe pain abdomen or like intolerance to high gastric output in terms of high relative aspirate and all, or because of the bad ileus. In them, we can consider slowly going for something called trickle feed at least 20 ml per hour. So or we can consider continuous feeding than that of the bolus feeding. We can change over from polymeric intact protein to semi-elemental, that is peptide based feed. So the tolerability will be increased if you use peptide based feed in patients with pancreatitis. Again, we can consider maybe worst scenario, we can use fat free diet in severe acute pancreatitis. So when it comes to trauma, particularly trauma means neurotrauma patients, so it's very important to remember they are going to have a lots of protein breakdown. So there will be loss of lean body mass along with the muscle mass and skeletal muscle mass. So feed them as early as possible within 24 to 48 hours. So you can give calories somewhere between 20 to 25 35 kilocalories per kg per day, and proteins we can give up to 1.5 to 2 gram per kg per day. To remember, these neurotrauma patients are going to be highly catabolic from so around 4th to 12th day of their post-trauma era. So is there any current recommendation for immunonutrition? So previous data suggest in trauma and burns patient we can use immunonutrients like glutamine and antioxidants. Again, so malnutrition is most common in severe traumatic brain injury. So they are going to increase their resting energy consumption by about 100 to 200% from the baseline. Consider them for the early enteral feeding. So again, burns, you have to use the gut in the burns. Don't keep them like nil by mouth for prolonged time because burn patient, they are more susceptible for infection. So it is true for the endogenous infection. If you keep them for more prolonged nil by mouth, it can lead to translocation of the gut organism and can lead to bacteremia. So you can use around 1.5 to 2 gram per kg with a bit high calorie, around 25 to 35 kilocalories per kg per day. So you can use some immunonutrients in burns patient. There is some evidence suggest with some favorable outcome in burns and trauma. Again, when it comes to end of life care, so the specialized nutrition therapy is not some sort of like obligatory in end of life care situation. So we have to respect the family and patient autonomy when it comes to continue the feeding in patients whom we decided for end of life care. So last entity, so oncology patient, whether it may be a solid organ malignancy or hematopoietic stem cell malignancy. So many of the cancer patients experience unexplained significant weight loss. We have to remember the weight loss in cancer patient may be related to their psychological perspective, mechanical problem or therapy related. So weight loss is an important prognostic indicator when it comes to oncology patients. The amount of weight loss depends upon the tumor site, stage, size, type of the tumor and the therapy which we are giving, whether it's a chemotherapy, radiotherapy or the surgical treatment. So all these things will decide on the weight loss in a patient whom diagnosed with cancer. So again, even 5% of weight loss among oncology patient leads to increased toxicity of the chemotherapy, decreased overall response to the therapy So increased unplanned hospitalization, increased length of stay, so decreased wound healing, so because of altered protein in the body, and decreased overall functional capacity, overall increase in morbidity and mortality. So how does weight loss happen in cancer patient? Is it different than that of other critically ill patient? Definitely yes, because in cancer patient the malignant tumor cells are going to cause increased proteolysis inducing factor, which leads to decrease in lean body mass. In the same time, interleukin 1, TNF alpha, interleukin 6, these are the pro-inflammatory cytokines, will suppress the appetite. So along with, so they are going to increase the resting energy consumption. So is there any difference between cancer cachexia and voluntary starvation? So we want to reduce our weight. Definitely, if you see both, the end result will be loss of weight. If you see more and more lean body mass is going to be lost in cancer patient as compared to like starvation patients. Body fat is going to be reduced over a period of time in a patient who is starved as compared to cancer patient. So total energy expenditure in a patient with starvation will decrease significantly as compared to cancer cachexia. So resting energy expenditure is going to be very high in cancer cachexia as compared to starvation. So in the same time, protein degradation is also going to be very high. So again, there is something called weight stabilization therapy. Can we use omega-3 fatty acids? So like alpha linoleic acid, icosapentaoic acid, and docosahexaenoic acid. Some evidence, if you use all these omega-3 fatty acids, it may act as an anti-inflammatory, so production of leukotriene and prostaglandins. So that's why which maintain the weight over a long period of time. So there are some clinical studies. So if you use these weight stabilizing diet with omega-3 fatty acids, which helps in weight gain and maintenance of a lean body mass, so improved physical quality of the life. So some benefit in terms of overall improvement. So again, how much to give? So we have to give near about 2 grams of this so-called omega-3 fatty acids. So if you increase more and more, it may not benefit in all the patients. So that's about the disease specific nutrition. So I'll come up with the overall concept of nutrition in critically ill patient. It's going to have some more slides. It may be a bit exhaustive also. So till now, subscribe to my YouTube channel. So wait for my more and more updated evidence based lectures in critical care medicine, emergency medicine, and anesthesia. Thank you all.